it's like 7 minutes from
we
here.
can do maybe, are you in the hotel here?
Yeah.
So we can maybe meet at like 8:30
Yes.
to go and go for coffee somewhere?
Yeah. That would work.
Okay, let's do that. Because I also want to talk to you about
Hello?
anything for our
Are we waiting for a timer? Should we start? Do you think we could... 5 minutes.
Who's our timer?
I don't know.
Intern from 7 years ago. She's here. She was for HRM. Or whatever the new one is.
What's her name? Anyone I know. Oh, I can ask.
But she was really nice. When she lived at my house. Because I used to have interns in my place.
I was waiting for the lady with the cards. Yeah. She'll... Green, 5 minutes. Red?
Those threatening.
Okay.
Those threatening.
Shall we go?
Let's go.
Hello? Welcome, hello? We can't... Annette and I can't see anything, can we?
Yeah.
Oh, there we are.
That's better.
Oh. Yeah, put the lights down. Welcome. We've got a fantastic 4 presentations today. So they're each going to do about 18 minutes, and there's a lovely timer down there to give some time for you to ask questions or for you to run and try and get your sandwich at lunch as well. So I'm Matt Hickman, Professor of Public Health at the University of Bristol, and I'm one of your chairs, and my co-chair is more important.
Well, I wouldn't say that. Good morning, everybody. I'm Annette Verster, and I work at the World Health Organization in Geneva at the Department of HIV, Hepatitis and STIs. And I lead the work on key populations, which include people who inject drugs and people in prisons. And I'm really excited to chair this session with fabulous speakers we all work with on a regular basis. So I'm looking forward to that. So we're going to have the presentations first, and then we'll have some half hour, hopefully, for questions and answers from you all to have a little bit of a debate, hopefully.
Yeah. Okay, and it's all about global coverage, and it's also, I must say, sponsored by, there they are, Inchu, and with which had a fantastic conference in Glasgow a couple of weeks ago. And so we, in a way, for those who are there, we're continuing the conversation and the debate about the global coverage. So let's start, shall we? So we're going to start with Louisa Degenhardt, who's from Sydney, from University of New South Wales, and she is the Scientia Professor, an NHMRC Senior Principal Research Fellow at the National Drug and Alcohol Research Centre, and she leads a multi-country, multidisciplinary team that has been really creating a wealth of evidence about the global burden of drug-related harm and injecting drug use. And so it's very apposite that she starts today. We were hoping that the paper was going to be... Anyway, she'll tell you about the paper that's just about to come out. Okay?
Yep, thank you. Thanks, Matt. So, you can see that. So thanks, everyone, for coming today. As Matt mentioned, the work that I'm going to be talking about today is really the result of the collaboration of a very large group of people, both in Australia and internationally, and with our collaborators at UN, EMCDDA, and many other people. So I just want to acknowledge that this is very much a group effort. So just to give a bit of a background and overview, some of you might have been aware of the reviews that we have done previously. The first one we did was published in 2008, led by Bradley Mathers, in work that we were doing as the Secretariat for the reference group to the UN on HIV and injecting drug use. We then expanded that to a focus on, and that was around, why did that? That just went ahead without me. We then expanded that to a focus on hepatitis C and hep B prevalence, and then have done a couple of rounds of reviews of the coverage of interventions for people who inject drugs. What I'll be talking about today is the next iteration of those reviews. So it's an update of estimates of the prevalence of injecting drug use. We've also been getting a greater amount of data on the characteristics of people who inject drugs, their exposure to risk and risk environments, the physical and mental health harms that people who inject drugs may experience, and then, as Matt mentioned, coverage of interventions. I'm going to focus on a couple in particular, but we're doing, for the first time, looking at coverage of hepatitis C testing and treatment, which is being led by Jason Grebley's group at the Kirby Institute. I won't go too much into the methods, but basically this was we went through multiple stages of systematically searching for information. So the first port of call was peer-reviewed literature. We then did a fairly substantial search of grey literature, so hundreds of websites across the world, including websites of UN agencies and the EMCDDA in particular. We sent out, in general, broad requests for information, but also approached people directly in country where there is information that we found that we weren't sure of, where there were gaps that we had identified that we thought might be able to be filled, or we wanted pieces of advice on what it was that we had or had not located. And all of this general approach was all consistent with previous reviews. The results, and I won't go into the details of how we pulled the data, but I'm happy to talk to people about that if they're interested in it. So in terms of the current reviews, we screened just over 40,000 papers or reports, and over 700 of those were eligible for one or more aspects of the reviews that we were doing, whether or not it was epidemiology or coverage. And we consulted with UN agencies and individuals, but particularly for the injecting drug use prevalence, a really detailed review by UNODC staff, in particular Kamran Niaz, which was extremely helpful. Just to give you an overview of the availability of data across the reviews and of evidence. So we've found evidence that injecting drug use is occurring in 190 of the 207 countries or territories across the globe, as compared to 148 in 2007. We've also seen an increase in the evidence of the extent to which that injecting is occurring, so we've now got prevalence estimates for over 100 countries. And similarly for HIV and hepatitis C, we've seen increases in the number of countries that are actually assessing prevalence of those viruses among people who inject drugs. We estimate that the number of people who inject drugs is just under 15 million, with a fairly wide uncertainty around that, which is around 0.29% among those aged 15 to 64 years. And we estimate that around 15% of people who inject drugs might be living with HIV, nearly 40% hepatitis C, current hepatitis C infection, and 8% hepatitis B. So this is showing the country-level variation in injecting prevalence. So there is clearly substantial variation in prevalence. Among the highest estimates that we located were in the United States and in the Russian Federation. And this shows you the estimates from the previous review and comparison with the estimates in current review across particular regions. Overall, you'll see there's a slight decrease in the estimated midpoint prevalence estimate from 0.33% to 0.29%. And there's a large amount of variation across regions in the extent to which those estimates were increased or decreased. Now, it's important to note that this does not necessarily mean that there's been a change in prevalence per se, because we have new estimates that might involve a different methodology that in part explains some of the changes. Additionally, we have more countries who have estimates where they were getting an imputed estimate before, and often those new estimates were lower than the imputed estimates. But at the midpoint range, it's around a 10% reduction in prevalence compared to the previous round of estimates. So as I mentioned, we collected a lot of data on characteristics of people who inject drugs. I'll just give a couple here. Just under 1 in 5 being women, just under 1 in 4 being under 25 years of age. Around 9% identifying as lesbian, gay or bisexual, and 0.8% identifying as transgender. These global estimates mask massive variation at both the country and regional levels for every one of those characteristics. These are some of the risk exposures and the health outcomes. Again, these are the global pooled estimates, and there's a lot of variation across countries and regions in the extent to which these occur. So as you can see, around 1 in 4 experienced homelessness or unstable housing in the previous year. Almost 6 in 10 have experienced lifetime incarceration. You can see almost 1 in 5 have experienced an overdose recently, which was typically in the past year. Almost 1 in 3 a recent skin or soft tissue infection. And although the data on mental health was much more limited, we found all of the estimates that we found were very high. And around 2 in 3, from the existing estimates, we estimate 2 in 3 had experienced depression recently. So this is showing you country-level HIV prevalence estimates. The purple indicating higher prevalence, and the paler yellows indicating lower prevalence. And you can see there in Eastern Europe, much higher prevalence. And this is current hepatitis C prevalence. So, and again, the levels are higher. There is still substantial variation at country level in what those estimates are. So moving on to coverage, there really wasn't much shift in the number of countries where we thought that opioid agonist treatment is being delivered between 2017 and 2022. Nor was there a shift. In fact, it went down by two countries overall in the number of countries that were delivering NSP. Some countries had started delivering NSP, but then a number of countries in Latin America have now ceased all needle and syringe programs in those countries. So we've actually gone backwards overall. But we do have more data on the coverage within countries. So we have more quantification of how many people are receiving needles, how many needles are people receiving, and how many people are in treatment. And I'll talk about why that matters in a later slide. As you can see there, we've got around 40 countries where there was evidence that naloxone is being distributed specifically to people who inject drugs, 15 countries where there is at least one supervised consumption facility, and 23 countries with evidence of drug checking services. And this is showing coverage of people receiving opioid agonist treatment, so the ranges being roughly in line with the WHO and UN agency guidelines. As you can see, there's a lot of countries where there is no OAT being delivered, particularly in Africa and Russia being two major gaps. But by and large, you can see that there's many countries in that light blue, which indicates very low level coverage. And these are the numbers, probably the easiest for you to see. Sorry, for those of you up the back, probably the easiest two columns are the two columns on the right. So the second from the right-hand side is the 2017, and then the far right is 2022. Most regions have low-level coverage. There are 3 regions where there's high-level coverage of OAT, and that's Australasia, Western Europe, and South Asia. North America has moderate coverage. This is, did that go? Oh, sorry, that's the wrong, I'll actually just go to the, sorry, that was out of order. So these are the regional numbers for needles distributed. So you can see here only one region has high-level coverage of needle and syringe distribution, and that's Australasia. There's moderate coverage in Western Europe and Central Asia, but it's low coverage everywhere else. And here you can see that at country level. So that light pink colour, which dominates most countries where there's quantification, is the lowest level of coverage. Now, I mentioned before that we were able to collect a lot more information on the extent of service provision this round compared to previous rounds. And the reason it's important to remember that is when you look at the global estimates and it looks like things haven't changed very much, what we have now is quantification or data that quantifies the extent of service delivery for many more countries, and the ones that have new estimates of how much of services are being delivered largely had very low levels of coverage. So probably countries that have only more recently been delivering those interventions. So the red bars are low-level coverage. The top row is coverage of NSPs in the 2017 review, and then the second row is coverage in the 2022 review. And what you can see is we've got a lot more, we have less blue and less grey in the more recent review in that second row, but a lot more red. So basically we've got more more countries delivering, but those countries are delivering at a very low level. A similar picture exists for OAT. So in the third row, that was the coverage estimates from the 2017 review, and then the bottom is the 2022 review. This slide shows you coverage of both OAT and NSP at country level. So number of needles and syringes provided is on the y-axis, and number of OAT recipients per 100 people who inject drugs on the x-axis. What you really want to see is that everyone is clustered around the top right-hand section of that figure, but unfortunately only 5 countries, all of them high income, have higher coverage of both OAT and NSP. So just to summarise, we have, if we're looking at the estimates between the 2 most recent reviews, we've got changes in estimates that have occurred in some instances because there's been a change in service coverage, so the removal of NSPs, for example, in Latin America. Some of the reasons for the changes in estimates are because new estimates of the prevalence of injecting drug use, for example, in India, are much higher, so that has an impact on estimates of coverage. And some of the reason for the estimates is because of changes in data availability and the quality of the data that we've got. We clearly still have low coverage of both services for most people who inject drugs globally, but there has been a modest increase in coverage at the global level, and in some instances there's been clear progress at the country level, so it's important to maintain that shifting focus between global and country level data. And that's the end of my talk.
Oh.
Then that's it.
Thank you very much.
I was to time.
Thank you so much, Louisa. That was just amazing. Really, really good to see the latest coverage data, and this is such an important piece of work. I have a few questions, but we will leave them for later. But also thank you for keeping really well on time. Our next speaker is Ciupagea. Monica has 20 years experience of working in the field of HIV prevention, treatment and care among people who use drugs, and in providing support to underserved communities, including, apart from people who use drugs, also sex workers, Roma communities, and prisoners. And she works at UNODC, and she is the expert on HIV/AIDS, with focus on drug use and HIV. And before joining UNODC, she worked also with Open Society Institute for several years. Monica, the floor is yours.
Thank you. Thank you very much. Well, my job today is to talk about successful models of implementation of harm reduction programs. And as always, it's very hard to talk about this topic when Louisa is telling you how poor the coverage is. But I'll try to do my best. So let me see if I know how this works. No. So a little bit about my organization. UNODC is the UNAIDS convening agency for people who use drugs and people in prison. These two populations are a key population for HIV interventions and one of the most marginalized one and very hard to reach. I will just talk a little bit about the political instruments that we have. Probably you are aware that there is a global AIDS strategy, and also at UNODC we have a strategy that is focusing on HIV prevention, treatment, and care among these groups. And also we have the Sustainable Development Goals that are giving us the instruments to implement the interventions among these groups. And then there is the political support, the outcome document of the UN General Assembly on drugs in 2016, who is bringing countries together to focus more on the health aspects of drug use rather than on the law enforcement part of this. And then we also have as I mentioned, the Global AIDS Strategy and the political declaration that followed, which is setting very clear targets for all the key populations, including people who use drugs. The harm reduction package is very clearly described also in the newest publication from WHO and also from joint publication of UNODC and WHO. And it's recommending, to implement these interventions not among people who use drugs, but with people who use drugs. But despite having all these instruments, as you could see, the coverage remains low. Louisa was talking about 190 countries reporting injecting drug use. Less than half have needle and syringe program, and even where there exists the coverage, it's very low, as you could see before. The same with opioid agonist therapy. Less than half of the countries have opioid agonist therapy. The number increased slightly, and there are countries who are starting opioid agonist therapy now or soon, but still the coverage is far from what we are looking for. So let's look at a country who actually managed to increase the access to opioid agonist therapy and needle and syringe program rapidly in the last years, and this is Kenya. And the lesson that we can learn from Kenya was that the strong political leadership and financial commitment from the country contributed significantly to rapid scale-up, because Kenya moved from 0 to 7,000 people on methadone in a very short time. And also retaining people in services and providing services of good quality involved also, talking and having an honest and open dialogue with the community. And I will let someone who was who is a client of the service to tell you more about this. I hope it works. Oh, okay. How can we have this?
That did not require me to abstain from drug use in order to be part of the program. So I was able to access a lot of harm reduction information about my body, about the effect of different drugs on my body, and I was able to make informed decisions about how to manage and or regulate my drug use. The OAT Center also acted as a one-stop shop for many services that I was previously resistant to get in the public health centers because of the fear of stigma and discrimination once they found out that I was a person who uses drugs. I've been able to access HIV prevention and management services at the OAT Center, TB prevention and management services, hepatitis information, as well as the hepatitis B vaccine. I've been able to access overdose prevention and management support at the OAT Center. I've also been able to access sexual and reproductive health support at the OAT Center. as well as have support groups that have allowed me to organize for the community of people who use drugs. The organization I work for now was in fact birthed at one of the OAT centers in Nairobi. I've also been able to access mental health support. Psychosocial support is normally quite expensive in many parts of the country and unavailable. So being able to access that at the OAT Center has been a big help in my daily life. The OAT Center has also helped me quite a bit in my social reintegration and family reintegration, as the professionals at the clinics have been able to explain to my family in a way that they can understand what my drug use looks like and be able to treat me in a non-judgmental manner.
So what
the OAT program?
Okay. So the lesson that we learned from Kenya is, treating people with respect, involving the community, and offering not only the methadone, but also access to other services was the key for their success. Accessing, for women who use drugs, accessing the services have even more barriers. I mean, we know that only 1 in 5 people who use drugs accessing treatment services is a woman. And, there are a lot of barriers, but we try to describe what would be the steps to address the specific needs of women who use drugs. And here you have some technical tools. But, it's always important, again, to know what are the needs of women who use drugs, what are their fears, and, losing the custody of their children is one of the highest, and also gender-based violence is a barrier. So all these have to be taken into account when services for women have to be established. And I don't have an example from one of the countries where we work in low and middle income countries, but I know about a good example from Spain for a service that is designed to address the women needs. So let's see this one.
Medicineras is a model, is a new model in Spain, where we provide a safe space for women and gender non-conforming people who use drugs. I think that the particularity of Medicineras is that we accept the drug use. We have safe space for using drugs, any kind of drugs, and in any way that you can use it or that you want to use it. But we don't put the drug use in the center. It's part of everything that we are doing, but it's not the main part. But we focus especially to give a comfortable space where we can build mutual support, solidarity, where we can do a lot of kind of activities like theater, photography, because we wanted a place where women and gender non-conforming people who use drugs can develop creativity, but most of the women that come to Medicineras are surviving multiple situations of vulnerability. Then the main problem that they have is not the drug use, but that they are homeless, that they are struggling with mental health issues, they have been incarcerated, then why they are using drugs most of the time is to cope with all the trauma and violence that they are surviving every day. Especially women who use stimulants are coming to our place looking for a quiet space where they can rest, where they can disconnect a little bit from all this violence and this pressure that the life is put into them. In that sense, we are trying to provide a full spectrum of harm reduction. They can rest, they have beds, they have a shower, they can washing machine. Most of the people who are working in Mentineros are also part of the community. They have life experience. Then and we are building the place all the time together. We have our assembly every week where we try to solve the problems, but also to create new spaces as soon as possible where they are needed, and to adapt all the time the place to the complex reality of the women.
One population that was not so much taken into consideration when we were talking about harm reduction is people who use stimulant drugs. Because all the time we were talking about people who use heroin. But we saw recently more and more that the number of new HIV cases are going up among people who use stimulant drugs. And we thought about how to design interventions that are meeting the needs of people who use stimulant drugs. And of course, there is a vast area. People are using cocaine, amphetamines, new psychoactive substances. So for all this, there are tailored interventions that can bring people to services. And the last example that I want to show you is the story of outreach program for people who use methamphetamines in Jakarta, in Indonesia.
And we have two main activities. Okay, the first one is outreach. We've been doing outreach since 2004 for people who inject drugs. And then since 2016, we also been doing outreach for people who use meth. Okay, we have one program manager, we have one field coordinator for outreach worker, and one data entry. So that's around 7 people are working with the ATS outreach project. So we put people that have the history with drug use, either in the past or currently. We always prefer that kind of people that work as the outreach team. So of course, aside from that, we also need to have them to have the communication skills and also the knowledge about harm reduction, at least minimum knowledge about harm reduction and other related issues. A typical day of an outreach worker usually begin in the morning by them trying to complete the daily report of yesterday's, because that's what usually they start their day with the daily report of the yesterday. And then after that, because most of the week is already been planned, so they already know where they have to go, at what time they have to go. So usually it's about them going into the field, meeting with the med user. It's about them meeting with the local stakeholder. It's about them making connection and trying to convey and send the message of harm reduction to people who use ATS or MET. We have a view kit that we distribute to our client. First of all, we have AC materials that consists of literature or reading materials, brochure, leaflet brochure that we provide to our clients that consists of harm reduction messages. How can they reduce the risk? How can they reduce the risk by using ATS? What type of things that, for example, eat before you use meth, or take a rest before you use meth, because after you use meth, you will reduce your appetite, and then you will also reduce you always want to be awake. So we try to tell that message to our clients. And then we also have aluminum foil, right? Aluminum foil that we develop based on the input of our clients. So we do a focus group before we develop it, like how long should the aluminum foil weigh, how thick the aluminum foil, and then we also distribute a lighter, right? A lighter that consists the message of our harm reduction message: eat, drink, sleep, and repeat. So that's what we want to convey to our clients. But currently, we also trying to provide a bong, right? A glass bong to our clients. Hopefully.
So what I wanted to point out with these three examples is that successful harm reduction programs are implemented when people who are designed for are involved, either as outreach worker or service provider, either consulted when the services are designed and implemented. So I think, this is a very important first step in having a successful harm reduction program. Then these services have to meet the people where they are. They should not wait for people to come to them, but they should do outreach and find them where they are. And then another important and crucial actually thing is to treat people with dignity, to listen, to treat them with respect, and then they will come and will make the most of the services provided. Thank you.
Thank you so much, Monica, for this really broad overview, and also to bring in stimulants and the need to have to work together with communities. So it's critical, of course. Our next speaker is Keith Sabin. I'm very happy to see him here. We work together in the same building in Geneva. Keith is the senior epidemiologist at UNH, and his focus is on improving monitoring of the HIV epidemic among key populations, which include people who inject drugs and people who use drugs and people in prisons. And before joining UNH, Keith worked with the New York City Department of Health and Mental Hygiene, with the Centers for Disease Control and Prevention, including PEPFAR, and with WHO, both in Geneva and in Vietnam. Keith is really the go-to person when we're talking about data and key populations, and he is a recognized leader in HIV surveillance, particularly behavioral surveillance, with lots of publications. So Keith, the floor is yours. Thank you.
Thank you, Annette. Bom dia, todo mundo. Can't see. Oh, there everybody is. How are the people in the back row doing? That's where I like to sit, too. They're really far back. Anyway, so there we go. So I'm going to start this out by prefacing that I'm going to try and build on what's already been said. I want to describe a little bit of what we know and what we don't know. And it makes me a little bit sad that I'm so happy to see that we had 2 or 3 more countries reporting over the last 5 years. That's a really low bar to cross, but it makes me happy nonetheless. I set my bar low. It keeps me a little more even-keeled. So one of the roles that we like to play in terms of our community of people who use data, who collect the data, and then work with communities to implement and use that data is around advocacy. Now, we have several advocacy tools that already put us in a reasonably strong position with the wind at our backs. The global AIDS strategy has been very clear that we are trying to end HIV as a public health threat. We want to have our communities at the center of that response, and that all of the targets that the global community sets are applied to all subpopulations. We're not cherry-picking those populations that are easier to reach targets with. It's everybody. We also have the recent World Health Assembly declaration that they want to eliminate hepatitis C, and then we have a UN statement about the decriminalization of drug possession for personal use. All of this helps us in our support of advocacy efforts. So the first question we have to ask about the data is, are we actually changing the trajectory of HIV infection? Well, the good news, there's no pointer. The good news here is that we do see in the gray overall progress globally. New HIV infections have been decreasing pretty steadily over the past decade plus. However, that is not, there isn't any significant contribution to that decrease among key populations. What we're seeing among sex workers and people who inject drugs is basically no change, right? And even worse, we're seeing an increase of new infections among men who have sex with men. And I'll add that among trans people, there's really no change, no statistical change either. So while there might be global progress, we're not seeing progress in some of the most impacted communities with whom we work. Now, these pies give us a sense of the distribution of where new infections are occurring in different parts of the world. And the relative contribution in sub-Saharan Africa remains small as compared to the rest of the world. But Africa's a big continent, and that's still a big number of people who need support and need services provided to them. And I'll come back to that in a moment. Now, one of the things that we're seeing, and that we have so far not done very well, is look at the intersections among the different key populations and their risks. This figure displays on the left sex workers, on the right men who have sex with men, who are also people who inject drugs. This is the HIV prevalence among those populations with those intersecting risks. And the red lines, if you can make it out, the red bars going vertically, are the HIV prevalence in the rest of the population. So the populations who inject, who also have other parts of their lives that expose them to HIV, we're not actually thinking about that in a coherent fashion. We are still very vertical in the way we approach interventions. So we have interventions for men who have sex with men, but not necessarily men who have sex with men who also inject drugs. So those men need to go to perhaps 2 different services in many settings. I want to come back to some of the data that we collect, or rather don't receive. Right? So 196 countries have committed at the UN to report their progress on the HIV epidemic in their countries. So there's a commitment to report to UNAIDS. These are the countries that have reported through 2021 HIV and hepatitis C co-infection. I commend those countries that have reported, but there's a lot of white on this map with no data. And so we don't have a good sense yet of what's going on in many countries where co-infection is involved. When we look at co-infection among incarcerated peoples, the numbers are even smaller. And this is data that should be available, and in many cases may be available, but countries haven't taken the steps to create a system whereby they can actually report it. And generally, if they're not reporting it to UNAIDS, it means that they don't have it in their Ministry of Health either. What we also see and what we report on our website are prevention services among incarcerated people. Here's an example from Tajikistan of opioid agonist therapy and the numbers of people that they're covering. And you can see the numbers have declined over time. So I'm not sure what that's about. That's condom distribution in prisoners. So that's one of the other things I wanted to point out with this slide, is that we collect the numbers of people who receive different services in different countries while incarcerated. So we do have a sense of how many countries are reporting different elements, including condoms and needle distribution, but the numbers remain relatively small. Now, I want to take a moment and focus on what I'd call the indignity of not being counted. Now, Louisa has just shown their estimates of the total number of people who inject drugs. Right? The number, if you look at the light blue portion of this bar, little under 6 million people who inject drugs were reported by countries to UNAIDS. That means those countries recognize that they have at least 6 million people who inject drugs in their communities that they should be addressing with services. The orange is another 2.5 million people who inject who are probably living in those countries that have already reported, but have reported an underestimate. They send us data from 2 or 3 cities in a country of hundreds of millions of people. So they've underestimated by about 2.5 million. And then the 5+ million on the top part of the bar are those people who were never counted. So that's our estimate of the number of people who inject drugs in countries that have not done the basic service to that community of even counting and understanding who is in that community, who is injecting drugs, and may be in need of services. Now, as you might suspect, a number of the countries that do not report are in sub-Saharan Africa, and we've done our level best to try and estimate for those countries that do not have data or do not collect data. Now, the numbers remain relatively small by country, but not unimportant. And we have not yet made a similar effort in other parts of the world, but that's something that Louisa is doing as well, although with slightly different methodology. But it comes back to the point that our advocacy should be based around the numbers that we estimate to exist, not the numbers that countries say they have. And that's a major challenge for us in terms of advocacy. We also collect data on coverage, similar to what Louisa has done, but here we compare the coverage to the targets that are set in the Global AIDS Strategy. So if you can make out the dotted orange line around the perimeter of this spider web chart, and then make out the blue lines within that, and the difference between the blue and the orange is the shortfall in coverage for each of those services. And let me say that Eastern Europe and Central Asia is the region with the highest coverage among people who inject drugs. So this is my best figure to present. Countries are falling short in achieving these targets, and it's happening for a number of reasons. And I'm going to speculate about some of those reasons over the next couple of slides. One of those reasons is stigma and discrimination preventing people from seeking those services. And Monica has just shown some excellent videos of people and their experiences, especially the Mutoni, the Kenyan woman, saying, I couldn't go to regular public health services, I had to go to the OAT clinic because of fear of stigma, fear of violence. This is a relatively new indicator for us, so we don't have many years of experience collecting it, but we can see in those countries that have collected it to date, the levels of reported violence, sexual and physical, by people who inject drugs is relatively high. And this is an important inhibiting factor in people seeking services. We have similar data showing that people don't seek services from healthcare providers for reasons of stigma and discrimination. The second impacting factor is probably around expenditures and financing of services. This is global availability of resources, money, for low and middle income countries in their HIV response. And what we see is a leveling of commitments, both by national governments and donors. We're not making progress in terms of raising money, and what we see as a target for achieving the goals that UNAIDS has set, we're not even getting close to that. We're just not seeing that rise. And we can attribute it to complacency, donor fatigue, or a wide field of competing priorities in a zero-sum game of financing. Nonetheless, what it all ends up is we don't have sufficient resources going into harm reduction and services for people who inject drugs. If we look at it by country, we see that some countries are maintaining or increasing their expenditures for people who inject drugs, for the services for them. We see other countries where the numbers are going down, such as Indonesia, which has reduced the number of people who inject that they report, and we're trying to ascertain if that is correct or not. And then Malaysia, we've seen they've had a shift in the way they're working with people who inject drugs, and we don't know if that shift is the result of this decline in expenses. But places like Kazakhstan and Kyrgyzstan, they still have epidemics among people who inject drugs, and the funding is diminishing. So what can we do to improve the data that are coming in, which will then be used to improve advocacy, which will then be used to improve the services? Number one, communities can and must lead this charge. I think most governments are really tired of hearing from the UN. They don't want to hear it. They don't want to hear from the big donors as much anymore unless there are dollars attached to that, and increasingly there are fewer dollars attached to that. So one thing we've looked at, UNAIDS and WHO together have looked at lighter and simpler surveys to collect data. So with the Georgia Harm Reduction Network, we engaged in a pilot where we interviewed and tested for HIV and hepatitis C, 2,000 people who inject drugs. It took 6 weeks. It cost $75,000 across 7 different sites. And this method just combined sentinel surveillance methods of snowball and outreach and looked at testing offered only within services that already existed. We also did a pilot in Uganda in an area where we had not seen any data from before, and we were able to uncover several hundreds of people who inject drugs in this rural area along the border with Kenya, and find that HIV prevalence was low but not unimportant. It was higher than the background rates in that area. And of those people who had already been identified as living with HIV, 100% of them were on ART. So that's some encouraging news. So what can we do to close the gaps? One, we have to hold national AIDS programs and ministries of health accountable. Sustainable development goals explicitly state that targets are for all subpopulations. So if a country claims that they're achieving or making progress on their sustainable development goal in terms of HIV incidence, if they're not doing it for people who inject drugs, they're not doing it. We have to hold the donors accountable in the same way, and we have to hold them accountable for supporting measurement efforts, for supporting surveys, and most importantly, for supporting the data analysis within the community and the reporting of those analyses. We know the data are collected very often and simply not reported. That's a big problem. Another issue is, where are the women? We just do not see very many women in the data. And we understand that in some countries, women who inject are very few in numbers, but there are countries where that's not true, and we still don't see the data. I think we need to make a more concerted effort to find women who inject drugs and make sure that they're receiving the services that they need. We have to expand expertise and the recognition of expertise within communities, and then look at multicultural community collaborations. If you have networks that are working effectively with sex workers, let's link them with the people who inject drugs and make sure that people who sell sex are also receiving services for injection drug use. One idea that we've floated is to support communities in data collection and reporting, and not just community-led monitoring, but to create a simple system whereby communities can report basic results directly to a larger system of data collection. And with that data collection, we would provide back the data to the communities in some organized format, and then the networks would have data with which to use for advocacy. And finally, we need to advocate for more funding. You know, what can we do? Can we go to the Clinton Foundation to further reduce the costs of DAA for hepatitis C treatment? Can we get the Global Fund to become more active in more countries on these issues? They're very active in some countries. They're a little bit laissez-faire in others. And will we be able to increase PEPFAR's willingness to become more active in these issues? The same with the Gates Foundation. So finally, I want to close by saying whatever we know, whatever I've presented today, you can also know all of the data are available on our website. Here's the link, and you'll have that when we share the slides after the conference. So thank you for your attention.
Keith, thanks very much. That was, I like that phrase, people who use data, but but I think also a perfect example of counting as public health action and research, not, can lead to change. Now, our final speaker before you get an opportunity to speak is, I'm really pleased that Judy Chang is here, and Judy's the Executive Director of the International Network of People Who Use Drugs, which is fondly known as INPUD. And Judy's has worked in HIV community-based health and research around, well, advocacy rather, for at least 10 years, and also brings 20 years of lived experience to her role. So thank you very much, Judy.
Thanks, Matthew, and thanks everyone for joining. So basically, my presentation today centers around the question, how can we use advocacy and community-led monitoring to improve coverage and quality of services to reduce drug-related harms? It's a big question, and I'll be basically drawing from INPUD's experiences in advocacy at the global level, where we interface and are active in the multilateral space to drive the issues that we see as important forward. Okay, so a lot of the advocacy successes that INPUD and its members, along with key populations, so sex workers, gay and bisexual men, transgender people, prisoners, and also people living with HIV, is really about getting policymakers, ministers of health and programs to go beyond disease responses, but recognize the complexity and plan to take action against inequities and injustice that are, at the end of the day, created and generated by people in power and bad policies and vested interests. So in our long-standing advocacy in 2021, we did see political opportunities really open up. So as Keith mentioned, the Global AIDS Strategy, this was finalized in early 2021, and in July of the year, the Political Declaration on HIV/AIDS was passed by the majority of member states. So the 2021 Political Declaration for the first time contained targets on societal enablers. So these targets were for countries to decriminalize, and these included targets to decriminalize drug use and possession and remove punitive laws. There was targets to reduce stigma and discrimination against people living with HIV and key populations, and also the 10 target on women, girls, people living with HIV and key populations, less than 10% to experience gender inequality and violence. So these are known as the 10-10-10, and along with these, there were the 80-60-30 targets on community leadership and recognizing the value and importance of community-led responses. So it was very significant that these were passed because in the lead up in civil society advocacy, there were definitely concerns that there would be a backtrack in progress, as we see the rise of conservatism, populism, and an anti-rights lobby. And of course, shrinking civil society space and smaller pots of funding. So basically, this is the first time in 40 years in the HIV response that we now have these global targets on societal enablers, and we see this as an opportunity. We believe that these can be leveraged to move the needle forward on access to quality services, but also, of course, to change the context and environments in which they're situated. I'm just checking I'm on the right slide. Oh, okay. So no doubt these targets are ambitious, incredibly ambitious, but we really need to be thinking of them as course correctors. HIV and COVID really demonstrated that epidemics thrive along the fault lines of inequity. where it is political will and choices that determine success or failure. We can have the latest biomedical advancements and treatments, but they're not going to get into the right hands without the right mix of laws, policies, and people. So compared with the UNAIDS fast-track targets, the 2025 targets do better serve our advocacy, as they can be used to demand our rights and hold governments accountable. But of course, as we all know, they need to be more than just numbers and words on a piece of paper. So success and progress towards these targets, really depend on the dissemination of knowledge of these targets, which we are seeing a gap in. 2, early and robust tracking of progress towards these targets at the national level. And as Keith mentioned, there is a framework on reporting on the 10-10-10 as part of the GAM, and there's also tools to track resourcing to community-led networks. And of course, global commitments can't just disappear into the void, as we have seen sometimes, but they must be aligned to regional and national action and mechanisms. So how do we get there in terms of communities demanding accountability? So communities and civil society allies need to be demanding alignment and find ways to leverage the targets. So it's important to remember, that social change has never been offered up. It's important that we're all keeping track of national decision-making processes and seeking entry on ways to advocate for the 2025 targets at the national level in the national strategic plans, but also in the Global Fund country coordinating mechanisms. Technical assistance funding will be critical as well, and this is available through UNAIDS technical support mechanisms and also Global Fund as well, short-term TA funding. And we know that funding for community-led responses and human rights, and specifically funding these pots in these areas, is critical to achieve the targets. In terms of community-led research and monitoring, this can be done through the Global AIDS Monitoring and also the UBRAF, but there are also, human rights mechanisms that can be used to drive government accountability, and communities can lead on this work. So just in the last year alone, the network of people who use drugs in Pakistan submitted a shadow report in the Universal Periodic Review, so to the Human Rights Council, and one of the priorities was OAT access. Also this year, Burundi, the Burundi Association of People Who Use Drugs, submitted their first shadow report on the UPR also. And in 2018, Assyria and Kyrgyzstan submitted a shadow report on the CEDAW, so the Convention on Elimination of Discrimination Against Women. At the program level, community-led research and monitoring by people who use drugs can be, of course, used to monitor service access and quality. But we also need to look at the other end, like once that work is done, that we do need program managers and policymakers to take this evidence, to take this data seriously and act on this evidence. We need anybody interested or involved in CLM, community-led monitoring. We also need tools to be adapted that are simple and relevant to community priorities. So just to share some of the photos from national workshops that Input has been supporting, and these are workshops to drive progress on the 2025 targets. The workshop series is called Our Rights, Everybody's Rights, and this was funded under the UNAIDS technical support mechanism and also with the support of UNODC HIV/AIDS section. So far, workshops have been run in Indonesia, South Africa, and Nigeria. But what we found there was that, as we kind of anticipated, there was barely any awareness or knowledge of the global 10-10-10 and 80-60-30 targets compared with the previous fast-track targets. And these were not being discussed in key national dialogue spaces. So I think it really highlights, the gap between global decision-making and national, and, that real efforts need to be made to bridge this gap. We've also run regional workshops in Sub-Saharan Africa, Eastern Europe and Central Asia, and the MENA region. So of course, in terms of other strategies, direct action against the war on drugs is critical. And here we have, communities, grassroots organizing, reminding us where the real problem lies and the need for action to end unnecessary deaths, incarceration, discrimination based on what we consume, our work, and what we choose for our own identities and bodies. So we really need to be using, of course, a range of methods for our advocacy and do. So this graph on the right comes from the Global AIDS 2022 update, and it shows the severe disparity between the amount of spending needed on critical enablers in key populations and basically what exists. So what else needs to happen? And what we've also been pushing for as well, we push that global health governance and funding bodies concerned about the HIV response, such as the Global Fund and PEPFAR, must align their strategies and funding allocations towards the 2025 and specifically the 10-10-10 targets. Two, we can't allow member states to ignore that that they signed off on these targets at the global level, and the need for integration of these targets into national planning. As mentioned, these targets do include funding targets for peer-led programs and community leadership, including and we can use them to push for resourcing, community-led advocacy on policy reform campaigning and gender equality. 3, national policies and programs should align with normative guidance, such as the key population implementation tools, so that for people who inject drugs is the I Do It, developed by UNODC in collaboration with Input, WHO, UNAIDS, UNDP, and USAID. And of course, I think, as people have heard in other sessions, the 2021 revision of the WHO Consolidated Guidelines on Key Populations. So, just in closing, these targets, of course, we have, they're 2025 targets, so there's 3 years until that, so of course, we need action to happen as soon as possible. The global community of people who use drugs is in the middle of dealing with concurrent crises, COVID, Ukraine, and of course the energy and economic crisis. And of course, in these situations, people who use drugs are always disproportionately impacted. But on the other hand, during these crises, as with HIV, it was communities that stepped up where health and social systems failed. And these systems failed because they were not designed to respond to emerging threats. The last few years have shown us how important it is to be ready to adapt and innovate, and this is what communities have always been best at. The 2025 targets are about dealing with entrenched laws, attitudes, and policies. We need to be finding ways to hold governments accountable and using both national and multilateral tools and mechanisms that we have at our disposal. Fund community leadership and challenge the prejudiced and vested interests that are situated in current laws and policies and mainstream norms and attitudes. And until we do so, we will continue to be not only setting up people who use drugs for failure, but also the global health response overall. Thanks.
Thank you, Judy. That was great. So that's the challenge. We forgot to say the title, didn't we, of the session, which was and a challenge for you as well. So how can we improve global coverage of interventions to reduce drug-related harm? So in a way, we want you to think about it in your own research. How can you do that? But also hopefully, some people to have a discussion with our panel about challenging them or hopefully not just agreeing with them about how do we improve the level of data. And because data comes from services, so the two should act positively together, as Keith has shown, and also the other speakers. So we've got 10 minutes, 15 minutes? Great. Can we have the lights up a bit, if that's possible? And if you wouldn't mind, there you are. Which first? I'm not going to go Jason first. Sorry, Jason.
I'll
I'm going over there.
Sorry, Jason. I come from a community organization that represents people who use drugs, and I have a couple of ideas about measurements. So one of the things that we get a lot of feedback is the lack of services for stimulant users, particularly substitution services. And I forgot to say, all of your presentations were really excellent, and I've always admired Louisa's work in this. And so this question is directed towards Louisa. A lot of the things that you measure are specifically around opioid users, such as naloxone, OTP. Would it be feasible to add measurements specifically directed, so distribution of smoking equipment, methamphetamine treatment services, and would it also be possible to add measurements for peer input into policymaking, into the kind of work that you do, and have you thought about doing that?
Thank you. Thanks, Mary. Great questions. The short answer is yes, we can definitely look for those data, but I don't know that we'd find very much. But we could definitely... No, Jason, we're not going to start it next year. But the next time we do the review, we can definitely add those in to see what we can find. But sadly, I think, when we started doing these in collaboration with the different UN agencies, a lot of the services that we were guided by what the core package of services was, and we've now expanded that. But I don't know what your views are, Annette and Monica and Keith particularly, around what the... I just think we'd end up saying we can't really say very much, but definitely happy to add that in.
Yeah, I think that's a really good answer. Unfortunately, also for treatment options for stimulants, there's still not a lot of... not enough, at least, to make clear recommendations from our side. But I think there's clearly a momentum, and we're looking more and more into stimulant use. And also, from my area, and for Keith and for Monica, coming from the infectious disease background, there's now coming also more data on prevalence of injecting of stimulants, and therefore a direct impact on incidence of HIV and hepatitis, as well as sexual transmission where there's no injecting. So, really good point. Shall we go to Jason?
But actually, just to say that that's part of it, is you advocate, and they should start counting it.
Consider it.
Yeah, and we always need countries to start doing things in order to start counting, so and to collect the evidence. Jason, I hope you have a similar question I would have, maybe?
Maybe. Jason Grebley from UNSW Sydney. So awesome presentations, everyone. Thanks so much. So I have two big questions, and I'm keen to bring some of the hallway conversations that some of us have been having throughout the conference into this bigger room. So the first question that I have is, I'm really curious to hear the panel's thoughts on, and I'm thinking about what are some concrete actions and who should be responsible for taking these sort of two big questions forward. And the first question is how can we better identify countries where there's potential catalytic opportunities where coverage of both OAT and harm reduction are near to being scaled up or have the potential to get governments to be thinking about this, and selecting countries and figuring out strategies to work together with people in country to motivate change, and taking examples such as Georgia, Egypt, and how do we do that, and who is best placed to kind of do that moving forward? That's question one, and anyone. And then second question, I'm just really keen, amazing presentation, Keith, around, a lot of work went into the investment cases around HIV testing and treatment. I'm not as aware of how much work has gone into the investment case around OAT and NSP globally. And I'm just wondering, what work should we be doing or could we be doing to strengthen the investment case data around OAT and NSP, particularly bringing in the concepts of HIV and Hep C prevention, given that in many countries NSP is cost saving, and whether that data, if packaged together with country level data, could be then used to advocate within governments.
I think Monica wants to respond to that.
Yeah, to the first question that you had, Jason, and actually a very good question. Well, you see, I mean, from our experience, we saw that the scaling up is happening when there is the, first of all, the community involvement. So, we have this new target saying that prevention should be delivered in 80% of the cases by community-led organizations, and this is something that we see, and it's working very well. But then you also need to have the political support at the country level. So have to have the country convinced that these are interventions that are needed and have to be provided like any other interventions for all the citizens. So they should not rely on external funding. It should come from the funding of the government. And then the third question is the funding available. And Keith and actually and Judy also mentioned that the funding for these interventions is low, and this is why we see. I mean, we've been seeing this data year after year after year. The coverage among this particular group is very low, but also if you look at the funding, it remained low over the years, both from international funding and from domestic resources. So the combination of these three will move things forward. But we still have 6 countries in that, the corner with the, the recommended coverage. And we need to increase that group.
Okay, so we might go Olav, because I know you've been standing there, and then over to there, if that's okay.
Okay, thank you. Olav Dalgeir from Oslo. Needle syringe programs and how to measure its uptake. In Oslo, we probably have the highest distribution number of the distributed clean needles and syringes globally, but we still had a prevalence of 45% Hep C in the drug user community. So it clearly doesn't capture the picture, and I'm sure you're aware of that. But wouldn't it be a better way to report uptake on NSP than just the number of syringes distributed? I mean, they're not used, all of the syringes in Oslo, hopefully. So we measure now 10 to 20% have had unsafe injections the last 4 weeks in Oslo, even with that high uptake. So I think, at least in Oslo, we should measure or aim at reducing that number. That's my question. So could it be measured in a more valid way?
Keith, Louisa, Keith?
Give it a shot. Is that on? Yeah. All right.
I saw this case study when I was a grad student, so that was a while ago. And even then they were saying, we can't look at OAT data or NSP data and link it to HIV prevalence, because the uptake of those services is usually later in an injection career. And so those people at increased risk have already probably acquired HIV before they've entered into the syringe programs. So it does require an earlier intervention And how do you measure that? This has been a challenge for 20 odd years, if not more, because the reality is, unless people are initiated to injection drug use in a way where they're going to seek clean needles routinely right from the start, there's a good chance they'll be exposed to one infection or another before they start using. What you see is a population protection effect, though, because if people who are living with HIV or hepatitis C are using clean needles routinely, then they're not transmitting it. But we don't necessarily see that impact as readily. So it's a much longer time frame. And so I don't know what time frame you're talking about, but.
But I don't think I was clear in my question, so could I just repeat? I think when you ask for measures, you actually give the countries targets. And I don't think the number of syringes is a good target, at least in Northern Europe. It sends a signals that we are good in Oslo, but we are not good with that number.
Yeah, it's true. We're going to have to continue that conversation now, unless Monica.
Can I add, because I can't keep quiet? Can I add to this? I mean, we see in countries that have a high coverage of needle and syringe programs that actually the incidence of HIV is going down. I mean, those countries in the upper right corner, they do report, some of them, there are years where they don't have HIV among people who inject. In some years, they have 1 or 2 cases. So this is the proof that, it's efficient.
Maybe just to add from the perspective of WHO, we've been asked to look at the efficacy and effectiveness of needle syringe programs time and again, but really we recommend sterile injecting equipment in medical care, and it's a no-brainer. You have to wash your hands, you have to use sterile equipment, and to keep on having to prove that it works is going to be a little bit of a waste of energy and resources in a very, in an area where there aren't many resources to start with. Next question, can you please introduce yourself?
Yes, thank you for the opportunity. My name is Yudil. I'm from Indonesia. And my question is mostly to Louisa. The governmental data on drug use prevalence from the government and the narcotics board in our country are frequently criticized by us, by NGO and academia, because we saw evidence of their inflating their numbers in order to continue their maybe war on drugs agenda, the fear-mongering, as well as to ensure funding from the governmental proportion and also from international donors. So my question would be is from your study, from your systematic review, did you also assess the accuracy of data in terms of maybe strength of evidence methodologically, but also importantly the risk of bias, especially in places with strict criminalization policy? Thank you.
Yeah. Thank you, yeah, and we did have a number of discussions around the Indonesian data ourselves as well. Yeah, look, there can be perverse incentives for countries to go either way, to either increase or indeed decrease their estimated level of injecting for different purposes. It's difficult in an ideal world, we would do some of the work that Matt has done a lot of when you're looking at evaluating the robustness of a prevalence estimate, which is you use a lot of other data sources to say how likely is it that this estimate is a realistic one? Does it match up with overdose deaths? Does it match up with the number of people being arrested who inject drugs, all of that kind of thing? But in a lot of the countries where we would love to do that, we haven't been able to identify that those data exist. But would definitely be keen to work with anyone who might be able to do that, because we're very aware that it's difficult for us to evaluate how good an estimate is when we don't have anything else to go on other than the veracity of the report that has been written that someone has put their name to and described the methods. Yeah. But agree, there's a number of countries where we think that's an issue.
Okay, thank you for being so patient. You're the last question, because otherwise Annette has to go and do a meeting, don't you? You have to go and speak.
Thanks, Matt, and thanks for an excellent session, Rebecca McDonald, University of Oslo. Keith mentioned the reduction in prison-delivered services in Tajikistan following 2016, which coincided with the mass pardoning or amnesty of, I think, 20,000 prisoners as part of their 30-year anniversary. And that leads me to my question. I was curious what you think in terms of building a bridge as people leave prison in this post-prison release period. What can be done in terms of data capture as well as interventions to protect people in this handover between government and civil society?
I didn't realize it was directed to me. That's good to know that I remember hearing about the mass pardon. I didn't connect it. That's absolutely a critical intervention. I mean, we've seen that kind of need of that community link from release to back to the community and assuring the continuity of services. I think it was somewhere in Massachusetts was the first one, a long time ago. But it's something that we've been talking about, again, for 20 plus years, but I don't see it being routinely done, but it is something that we advocate for. And I think it's a fair point to say I don't think we measure that, and that's a policy initiative that could at least be queried in the policy instrument at a minimum. Yeah. Thanks.
Okay. Thank you so much for coming here. And Lucas, you're going to have to ask because we're going to have to stop. But
okay, thank you very much.
Yeah, but we hope to see you through the... Please put your hands together for all of the speakers. And if there are anyone's further conversations, come down the bottom.